This conference will now be recorded.
So today we'll be talking about epistaxis. Before that, I'll be giving you a small gist on the mechanism of clotting. It is just a refresher for you people who have just come from physiology and pathology. These are the various contents under which I'll be talking about today: hemostasis and clotting mechanism, laboratory tests, vascular anatomy of the nose, epistaxis, its classification, its etiology, and its management. Normal hemostasis is a consequence of tightly regulated process that maintain blood in a fluid state in normal vessels, yet also permit the rapid formation of a hemostatic clot at the site of vascular injury. So there is a tight hemostasis mechanisms which is happening in the entire vascular system, which maintains the blood in fluid state, and whenever there is an injury, there's immediate clot formation. The vascular wall has an intact endothelial cells which prevents platelet adhesion, and it prevents coagulation factor activation. And when there is a direct injury, there is stimulation of inflammatory cytokines, which leads to various stages of clot formation, namely arteriolar vasoconstriction, platelet plug formation, and clot formation. Arteriolar vasoconstriction is an immediate transient response. It is a neurogenic response. Whenever there is an insult in the vessel wall, there is a release of endothelins from the vascular endothelial layer. And these endothelins will cause immediate reflex vasoconstriction, which prevents further bleeding. Platelet plug formation. When there is an endothelial injury, there will be exposure of the subendothelial matrix, right? So the platelets go and adhere to these extracellular matrix, this adherence leads to release of more inflammatory cytokines like thromboxane A2, ADP, and this leads to more platelet aggregation, and plug formation happens at the site of injury. So this is platelet plug formation. You can see the platelets coming and adhering to the extracellular matrix with more release of ADP and thromboxane A2. It causes more platelet aggregation. These prostacyclins are protective against this platelet aggregation, and these are released by the endothelium. And when there is a breach in the endothelium, there is a reduction in prostacyclins, so more platelet aggregation happens. So once the platelet aggregation happens, it stimulates the clotting pathway, the extrinsic and intrinsic pathway. The extrinsic, you all know about the pathways of coagulation. The extrinsic pathway stimulated by tissue factor in presence of factor 7. It converts prothrombin to thrombin, and the prothrombin converts the thrombin converts fibrinogen to fibrin, fibrin to fibrin polymer, and the clot is stabilized. All right. The coagulation cascade. The extrinsic pathway is by an exogenous trigger, an intrinsic pathway by exposing factor 12 to thrombogenic surface. For both extrinsic and intrinsic pathway, there is a common pathway, that is it leads to the formation of prothrombin activator. In the extrinsic pathway, it is initiated by tissue thromboplastin, whereas in the intrinsic pathway, it is initiated by platelets. So this is the extrinsic pathway. When there's a tissue trauma, there is release of tissue thromboplastin. The factor 10 is converted to activated factor 10 in presence of activated factor 7. And this activated factor 10 leads to the formation of prothrombin activator, which converts prothrombin to thrombin, which is the common pathway in the coagulation cascade. The intrinsic pathway, as you all know, when there is contact with collagen, factor 12 is converted to activated factor 12, and factor 11 is converted to activated factor 11. And in presence of factor 8A, that is activated factor 8, the 9 is converted to activated 9, that is 9A. And this activated 9A converts 10 to 10A, and then prothrombin activator is formed, which in turn converts prothrombin to thrombin. So this is the common pathway, the 10 to 10A, and prothrombin to thrombin, fibrinogen to fibrin, and this in presence of factor 13A, that is the activated factor 13, undergoes cross-linking and leads to fibrin polymers, which forms the clot. So what are the various laboratory tests when a patient presents with epistaxis? We have to check all these parameters. The platelet count, which is normally around 1.5 to 4.5 lakhs. The bleeding time, which is normally 2 to 6 minutes. It checks the efficiency of formation of platelet plugs. And then the prothrombin time, which is around 12 to 15.5 seconds. It checks the efficiency of extrinsic and the common pathways. The INR, which is an express ratio of patient's prothrombin time to the mean prothrombin time, this also gives an idea about the extrinsic and the common pathways. The APTT, which is normally 26 to 37 seconds, which shows the efficiency of the intrinsic and the common pathways. Going on to the vascular anatomy of nose. Till now, is it okay?
Yes, sir. Yes, sir.
Okay.
Yes, sir.
I think anatomy of the nose has already been dealt with for you by our chief. I'll be talking only relevant vascular anatomy. The nose is, supplied by both the external and the internal carotid artery system. The external carotid artery system is by the internal maxillary artery, that is the third part of the maxillary artery, and the facial artery. Whereas the internal carotid system is by through the ophthalmic artery, through the anterior and posterior ethmoidal arteries, which are branches of the ophthalmic artery. So this is the vascular supply of the septum of the nose. You can see the anterior and posterior ethmoidal arteries, which are branches of the ophthalmic artery, which in turn is a branch of the internal carotid artery. And then the septal branch of Sphenopalatine artery, this is called the artery of Epistaxis. This is a major vessel which supplies the septum. And then the septal branch of the superior labial artery, which is a branch of the facial artery, and also the septal branch of the greater palatine artery, which comes through the incisive foramen. The lateral wall is supplied by the lateral wall branches of the anterior and posterior ethmoidal artery. The lateral wall branches of the sphenopalatine artery coming out through the sphenopalatine foramen. It divides into the middle turbinate and the inferior turbinate branches supplying the lateral wall. And then the lateral wall branches of the alar branch of the facial artery and the branches of the greater palatine artery through the incisive foramen. You see this internal and external carotid artery system is a watershed area. This is the middle turbinate, right? It gets attached at the roof of the nasal cavity. This acts as a watershed area of supply between the internal carotid system and the external carotid system. This entire area is supplied by the external carotid system, whereas this area above the attachment of the middle turbinate is supplied by the internal carotid system. All right. So the external carotid artery facial branches are nasal septal rami or superior labial, lateral nasal artery, ascending palatine artery. Maxillary branches are greater palatine and the sphenopalatine. The most important vessel which you have to know as far as epistaxis is concerned is the sphenopalatine artery. It enters the nose through the sphenopalatine foramen from the pterygopalatine fossa. It divides into posterolateral and the posteroseptal branches. The posterolateral branch supplies the inferior and middle turbinate and the lateral wall of the nose. And the posterior branch, it runs across the anterior face of the sphenoid, and then it undergoes an undulating course. It is very tortuous and comes up to the caudal end of the septum and then supplies the little's area. The descending palatine is a branch of the terminal end of the internal maxillary artery. It traverses inferiorly in the greater palatine canal and then anteriorly along the palate and supplies the anterior part of the septum through the incisive foramen. You can see the septal branch of the sphenopalatine artery. This is an endoscopic view of the right nasal cavity, the posterior part of the right nasal cavity. This is the septum on the left-hand side for you, and this is the posterior end of the middle turbinate. This is the choana, the superior part of the choanal arch, and this arch is the ostium of the sphenoid sinus, and in between the choanal arch and the ostium of the sphenoid sinus You can see the septal branch of the Sphenopalatine coursing on to the septum, and then it comes anteriorly up to the caudal end of the septum. The internal carotid system consists of the anterior ethmoidal artery, posterior ethmoidal artery. These vessels have only a minor supply to the nose. The anterior ethmoidal artery runs under the superior oblique muscle in the orbit, enters the anterior ethmoidal foramen, and through that into the ethmoidal roof of the ethmoid sinus and the nasal cavity, the ethmoidal fovea, and it divides into and gives branches to the meninges, the meningeal branch, and a larger branch to the nasal roof, olfactory cleft, and the superior turbinate. I was talking about the watershed area, right? So the superior part of the nose is supplied by these vessels. Posterior ethmoidal artery is present in 80% of the individuals. It runs in the orbit, it runs over the superior oblique muscle. Through the posterior ethmoidal foramen, it enters the posterior ethmoidal air cells in the roof, and it gives branches to the posterior superior nasal cavity, olfactory sulcus, and the sphenoethmoidal recess. What is the problem as far as the anterior ethmoidal artery is concerned in case of epistaxis? When we do a lot of nasal surgeries, right? We do endoscopic nasal surgeries. In certain patients, this anterior ethmoidal artery, it does not run in the roof of the nose. It does not run in the roof, whereas it might be situated loosely in a mesentery in the ethmoidal air cells. And this is a high risk factor when we do a lot of manipulation with instruments. It can we can even transect the vessels. This is a small caliber vessel, it is only 0.8 mm in diameter. It's not that it is going to bleed significantly, it can be easily controlled. But the problem is this vessel, because of its elasticity in the mesentery, it retracts into the orbit. So when it retracts into the orbit is confined space. It is a tight space, it is confined all around by bone. So what happens is bleeding inside the orbit leads to increased intraocular pressure, and this might lead to optic atrophy and blindness. So that is the most important thing which you have to remember about this anterior ethmoidal artery. This is the ophthalmic artery with the anterior ethmoidal branches through the anterior ethmoidal foramen, and the posterior ethmoidal branches through the posterior ethmoidal foramen. Little's area, the locus valsalvae. This would have been dealt with you in anatomy classes. The Little's area is a small area in the caudal antero-inferior part of the septum, which is supplied by all the vessels, the anterior ethmoidal, sphenopalatine, septal branch of sphenopalatine, greater palatine, superior labial. The only vessel which does not supply this Little's area is the sphenopalatine, the posterior ethmoidal artery. This is an arterial plexus mainly. There is a vessel called the retrocolumellar vein, which is the most common cause of epistaxis, venous bleeding in children. Okay, the Little's area is an arterial plexus. Arterial plexus bleeding is more common in children, whereas there can be a venous bleeding in children because of this retrocolumellar vein. This is a small vein which is running perpendicularly, parallel along the columella, and then it enters into the floor of the vestibule and then through the lateral wall, and then it drains into the alar branch of the facial vein. And this vein undergoes ectasis. Sometimes it's bulged out, and when there is a frequent nose pricking by children, it breaks open and bleeds. So that's the most important thing about the retrocolumellar vein in young children. The venous drainage of the nose is the veins follow the arteries within the mucosa, with an exception that there is a periarterial venous cuff around the interosseous portions of the inferior and middle turbinate arteries. From the lateral wall, the sphenopalatine vein follows the sphenopalatine foramen into the pterygoid venous plexus and into the internal jugular vein. From anteriorly, the superior labial and the greater palatine vessels drain into the facial vein and then into the external jugular vein. Woodruff's plexus. This Woodruff's plexus is a venous plexus which is situated in the inferior meatus just behind the posterior end of the inferior turbinate. This is called a nasopharyngeal plexus. It is a venous plexus. This is the most common cause of epistaxis in adults, especially secondary to hypertension. So epistaxis, what does epistaxis mean? It is a Greek terminology. The epi means external, stasin means dripping from drip from the nose. So it's an external dripping of blood from the nose, and it is the second most common cause of emergencies in ENT services. The first main cause being stridor and tracheostomy. What is the classification? We classify it as primary and secondary. Primary is when there is no causal factor. Secondary is there is a proven causal factor. It can be childhood or adult epistaxis. Childhood when it's less than 16 years. Adult when it's more than 16 years. Anterior is when you know the piriform aperture, right? The bony aperture of the nose. If there's any bleeding anterior to this piriform aperture, then it is called as the anterior epistaxis. And when there's bleeding posterior to this piriform aperture, it is called as posterior epistaxis. It has a bimodal age incidence, that is, it is common in children and then older age group. It has a male preponderance and it's common in cold winter months. One is because of rapid changes in temperature and humidity, and the other is because of rhinosinusitis. It can also happen in hot, dry climate with low humidity. Changes from cold outside environment to warm, dry one can also stimulate an epistaxis. The most often the cause of epistaxis is unknown. It can be from the Little's area or from the retrocolumnar vein, which I already talked about. It can be secondary to infection, vestibulitis, foreign body, nasal allergy, and it can be secondary to trauma to the nose by nose picking. This is the most common cause of secondary epistaxis in children. You know, they keep poking the nose all the time, and it bleeds from the Little's area. And then surgery and septal perforation are the other causes. The less common causes, the local involved with septal deformities. A sharp septal spur can bleed from the summit of the spur because of even a minor trauma or a dryness. It can bleed from the septal spur. And also tumors, benign tumors and malignant tumors and vascular abnormalities, which I'll be talking about later. Then systemic conditions like coagulopathies and hereditary hemorrhagic telangiectasia. So broadly, it can be classified into local and general causes. The local causes include congenital and acquired causes. The congenital causes, the local causes include unilateral choanal atresia, meningocele, encephalocele, and glioma. The acquired causes, the infective ones like acute viral, bacterial, and fungal infections, chronic specific infections like tuberculosis and syphilis, and non-specific chronic infections, and inflammatory conditions like rhinosinusitis, nasal polyposis, and neoplasms, the benign and malignant ones. It can be secondary to trauma, that's iatrogenic facial trauma, foreign body, barotrauma. It can be idiopathic, drug-induced rhinitis medicamentosa, which I talked to you about in the last class, that can cause epistaxis, and inhalants, toxins can cause. The general causes include bleeding disorders like coagulopathies, platelet disorders, blood vessel disorders, hyperfibrinolysis, and certain drugs which are taken by patients, neoplasms, idiopathic, and others. The coagulopathies include inherited ones, hemophilia A and B, von Willebrand disease, where there is a deficiency of von Willebrand factor. The acquired causes include anticoagulants. You give, warfarin, coumarin, and all those derivatives. And liver disease in alcoholics, where there is reduced coagulant, procoagulant factors, and vitamin K deficiency and disseminated intravascular coagulation. The platelet disorders, thrombocytopenia, which can be congenital or acquired due to marrow failure, in aplasia, drugs, and infiltration, and increased consumption due to DIC, hypersplenism, and massive blood loss. And platelet dysfunction conditions, the congenital ones like von Willebrand's disease, Bernard-Sollier syndrome, and Glanzmann's thrombocythemia. Sorry? What is Bernard-Sollier syndrome? Hello? Hello? Am I audible?
Yes, sir.
What is Bernard-Sollier syndrome and Glanzmann's thrombocythemia? Glanzmann's thrombocythemia is one of the platelet dysfunction, wherein there is glycoprotein 1b deficiency, whereas in Bernard-Serlier syndrome there is deficiency of glycoprotein 2b3a. There is a generalized thrombocytopenia and reduced platelet aggregation, which leads to reduced coagulation and more bleeding. Acquired conditions of platelet dysfunctions like using drugs. Excuse me. Sorry. Am I audible? Hello?
Yes, sir.
Yes, sir.
Audible?
Yes, sir.
Yes, sir.
Yes, sir.
Hello?
Yes, sir.
Yes, sir.
Okay. Sorry, there's some interruption. Okay. So the acquired causes of platelet dysfunction are the drugs like, NSAIDs, which are used commonly. Aspirin especially can cause a platelet dysfunction. And then myeloproliferative disorders like AML and CML. Blood vessel disorders like hereditary hemorrhagic telangiectasia and osteogenesis imperfecta. Yeah, acquired conditions like amyloidosis, vasculitis like SLE, lupus, and vitamin C deficiency. Hyperfibrinolysis states like congenital alpha-2 antiplasmin deficiency and acquired conditions like malignancy, DIC, and fibrinolytic therapy. That is, we give heparin in many conditions which can cause more bleeding. These are the various drugs which can cause epistaxis: aspirin, dipyridamole, anticoagulants, chloramphenicol, methotrexate, immunosuppressive drugs, and alcohol. How do you go about when a patient presents with epistaxis? The first and foremost thing is if the patient is unstable, that is, the vitals are unstable, there's a low BP, hypotension, and the pulse is rapid and low pulse, then the patient has to be resuscitated first. Once that resuscitation is done, once the patient is stable, then you go ahead with the history. The most important aspect in history is that you have to ask for duration, the site of bleeding, the amount of bleeding, what are the precipitating factors, is there any medical or drug history that the patient is taking, family history, is there history of easy bruising and alcohol intake. And we have to examine the vitals, the ENT examination, and then the systemic examination. And laboratory studies, as I already mentioned, the blood counts, grouping and cross-matching, coagulation profile and biochemical tests, and imaging studies, angiography, CT, MRI. These are done if we are suspecting intranasal pathology. How do you manage the patient? It is broadly classified into acute bleed in children, recurrent bleed in children, adult primary epistaxis, adult recurrent epistaxis, and secondary epistaxis. When there is a bleeding child who is presenting to you, the first thing is to reassure the parents. Okay, they should not panic. You have to reassure them, and then you can ask them to pinch the nose and make the head forward. This will stop the bleeding in most of the cases. It's most of the cases it's a simple bleeding and it stops with this simple maneuver. Just pinch the nose and bend forward. Then you have to examine the nose. You have to elevate the tip and examine with a speculum. The anterior rhinoscopy speculum we have to examine with. If there is any clot, you can put a low pressure suction and remove the clot, and then you look for the bleeding spot. If the bleeding spot is visualized, then you can cauterize the spot. This can be done as an OPD procedure as well. It is you can use a silver nitrate cautery to cauterize the spot. If there is an uncontrolled bleeding, then you have to resuscitate the patient, and then you have to plan for a nasal pack or a balloon. The nasal pack can be an anterior nasal packing or a posterior nasal packing, which I'll be telling you later. The posterior nasal packing, as far as children is concerned, You can do it only under general anesthesia because it's a very uncomfortable procedure and the children will not cooperate for it. When there is a recurrent bleeding in children, when the parents give a history of recurrent bleeding from the nose, then you have to assess for the precipitating factors. Is there a history of allergic rhinitis? Is there a history of any long-term medications? Many times there is self-limiting, epistaxis from the Little's area or the retrocolumnar vein. As I was already talking about nose picking, it's the most common cause of self-limiting recurrent epistaxis. Even intranasal steroid sprays can cause recurrent bleeding, and vestibulitis due to retained foreign bodies can cause. And bleeding, if there is history of bleeding from other sites or there's a family history, then you have to do all the laboratory investigations, CBC, coagulation profile to rule out the congenital causes like ITP, idiopathic thrombocytopenic purpura, and von Willebrand's disease. If there is recurrent epistaxis in children, then you have to, in infants, then you have to suspect meningocele or encephalocele. This is a condition where there is a defect, a congenital defect in the skull base, where either the meninges alone or the brain matter itself, that is encephalocele, prolapse into the nasal cavity, and this can be diagnosed by endoscopy and imaging. In adolescent boys, if there is a recurrent torrential bleed from the nose, recurrent torrential bleed in an adolescent male, you have to suspect what is called as juvenile nasopharyngeal angiofibroma, that is JNA. It is diagnosed by endoscopy and other imaging investigations like CT and MRI. Nasal parasitosis, that is nasal myiasis, is quite rare, and nasal mycosis, when there is a fungal sinusitis, which can be secondary to immunosuppression or chemotherapeutic drugs. Rhabdomyosarcoma occurs in children. There's a malignant tumor which happens in the nose, which extends into the orbit and into the brain, and it can cause cranial neuropathies as well as eustachian tube dysfunction. Vascular abnormalities also can present with recurrent epistaxis, which can be diagnosed with imaging, like AV malformations and angiomas, and all those conditions can be diagnosed by imaging. So when there's patient presenting with recurrent, epistaxis, how do you manage them? You give them, lubricants to apply at the site of bleeding. As if there is a little area bleeding, you can apply lubricant in that area to prevent drying. You can use petroleum jelly or Vaseline or even antibiotic creams. Antiseptic creams can be used to be applied at this region. And then you can do cauterization of the little area or the retrocolumnar veins. Silver nitrate or electrocautery is used. You can also use a laser therapy, fibrin glue, endoscopic ligation, and embolization. Endoscopic ligation and embolization I'll be discussing in detail in the later slides. And also you have to treat the associated conditions like allergy with intranasal steroids and antihistamines. Septal deviation of spur, if it is present causing epistaxis, you can do a limited septoplasty. And hereditary hemorrhagic telangiectasia, you have to manage the acute bleeds. And surgical treatment is by way of dermoplasty, that is, the entire nasal mucosa is removed and a split thickness skin grafting is done in the nose to prevent exposure of the blood vessels. In hereditary hemorrhagic telangiectasia, there is a breach everywhere in the nasal mucosa with exposure of the telangiectasic vessels, leading to recurrent bleeding. And this can be prevented by removing the entire mucosa and lining the subepithelial tissues with split thickness skin graft. Malignancies have to be treated by palliation, repeated transfusion, platelet therapy, and if there is profuse bleeding, then it can be controlled by nasal balloon or a postnasal pack. Adult primary epistaxis can be due to NSAIDs, most common cause. Hypertension is the most common cause in adult primary epistaxis. The other causes are NSAIDs, alcohol, hypertension, and septal abnormalities. This is the flow chart which you have to follow. When patient presents with epistaxis, you have to examine the patient, first resuscitate the patient, and then you examine the patient. You do even an endoscopic examination. If you're able to identify the bleeding spot, then you cauterize the bleeding spot either with an electrocautery or with the silver nitrate. And if still there is no stoppage of bleeding, then you start on indirect therapy, that is the anterior nasal packing. And if still there is continued bleeding, then you do a posterior nasal packing, and you treat the underlying cause like septal surgery. And if there is still profuse bleeding, you can even think of ligation of the blood vessels in the region of the nose. So this is when the vessel is located, you do a direct therapy with bipolar. And if there is a bleeding control after all this management, then you pack the nose, wait for 48 hours, and then you remove the pack after 48 hours. If there is no further bleeding, then the patient can be discharged. If there is continuous bleeding after all these maneuver, then you think of what is called as the angiography and embolization of the blood vessel in the region of the nose. So resuscitation, assessment, direct or indirect therapies, and surgical management. Resuscitation includes just pinching the nose and head forward, which stops many of the bleeding. Uh, you wait till a normal bleeding time or a clotting time, say 5 to 6 minutes. Just pinch the nose and keep the head downwards. It will clot automatically on its own, and the bleeding will stop. Then you check for the circulation, airway, and breathing, the ABC of resuscitation. You check for these, and then you take the history and examine. Then administer intravenous access and do the baseline blood investigations, give fluids and blood transfusion. The Trotter's method is no longer done; it is condemned. This is the Trotter's method, which was done before. The patient used to sit forward and allow to bleed into the basin, allow to bleed that the patient develops hypotension that will stop bleeding. But many a times this leads to cardiopulmonary arrest. So this has been totally abandoned, and it should not be used, and it should be condemned. This is the normal method. This is the right method of pinching the nose and bending forward. This will prevent further bleeding, and this head upwards should not be done while doing this maneuver. Direct therapy, bleeding point specific therapy, silver nitrate cautery, bipolar diathermy, or electrocautery. You can directly use miniature targeted packs at the site of bleeding. And if there is a posterior epistaxis, then you do an endoscopy. Under endoscopic control, you use a bipolar cautery to cauterize the site of bleeding. Indirect therapy is when you fail to locate the site of bleeding. You do nasal packing, anterior and posterior nasal packing, and then you give systemic medical therapy to reduce the bleeding. Surgical management includes posterior packing, ligation of the blood vessels, embolization, angiography and embolization of the vessels, and septal surgery for removal of spurs. So silver nitrate cautery is available in 75 and 95% preparations. It can be used at the site of bleeding. The only problem is it can cause a septal perforation at the site of cauterization, and it can cause black staining at that site. So this is a silver nitrate cauterization. You can see how markedly engorged the blood vessels are. You place the stick with the silver nitrate on the side, and it causes complete blanching of that area. The engorged blood vessels are gone, and this leads to control of epistaxis. The same way the electrocautery or diathermy also functions. It's easier to apply as compared to silver nitrate. And after direct therapy, you give a hemostatic dressing, which can be removed after 24 hours. So this is, bipolar diathermy being done at the site of epistaxis. So these are the next are the indirect, control measures. That is nasal packing. There is various materials available for packing. The anterior nasal packing, especially These are the traditional ribbon gauzes. It is any gauze which can be rolled into a ribbon. It's a 0.5-inch ribbons. They can be used coated with petroleum jelly or with a BIP pack, bismuth iodoform paraffin paste. The other things which can be used for nasal packing include Merocel, nasal balloons, procoagulant nasal packs, which include rapid rhino. So these are the ribbon gauzes, okay, which can be impregnated with petroleum jelly, and it can be packed in the nose. It can be kept for 24 to 72 hours in the nose. We have to give an antibiotic cover to prevent, toxic shock syndrome, and success rate is around 60%, and it's very cost effective. This is how the anterior nasal packing is done with ribbon gauze. Layer by layer, it is packed in the nose, and this prevents further bleeding. BIP pack bismuth iodoform paraffin paste. It contains 1 part of bismuth subnitrate, 2 parts of iodoform, and 1 part of sterile liquid paraffin. These have topical astringent, antiseptic, and antibacterial activity, so they do not require an antibiotic cover, and it can be kept in the nose for 48 hours to 72 hours. Merocel is a polyvinyl alcohol. These are the Merocel packs, which when we just fill water, it just swells up and fills the nasal cavity. It's absorbent. It's a non-absorbent nasal pack, and it's long-lasting and easy to insert. 1 second. This rapid rhino contains carboxymethyl cellulose. It is impregnated with carboxymethyl cellulose, which helps in platelet aggregation. It forms, it's inflated with air, and it's easy to insert, and this prevents epistaxis. Nasal balloons can be used to control epistaxis. These are the nasal balloons which have 3 lumens. The 2 lumens, one balloon fits in this is a nasal balloon. One balloon fits in the nasal cavity, the other one in the choana, and there is a 3rd lumen which allows for suction and for breathing. Even Foley's catheter, the urinary Foley's catheter can be used to as an alternative to this nasal balloon to prevent epistaxis. The absorbable ones are Surgicel oxidized cellulose, gelatin forms like gel form, and Flowseal. Flowseal is a combination of thrombin with gelatin. It can be applied like a fluid. This is Flowseal, which can be applied at the sites of bleeding to stop the bleeding. What are the complications of anterior nasal packing? It is very painful. It can cause shock, trauma to the columella and the nasal mucosa. And if during the maintenance phase, that is the 24 to 48 hours, it can lead on to hypoxia, vestibulitis, sinusitis, toxic shock syndrome, and eustachian tube obstruction, leading to otological complications. And even after removal of the pack, there can be late complications like adhesions, septal perforations, velopharyngeal incompetence, and pack granuloma. Posterior nasal pack. This can be done under local anesthesia in adults, whereas in children it should be done under general anesthesia. There is a traditional Belloc pack which I'll be showing. Even Foley's catheter or Brinton catheter can be used. These have to be covered by antibiotics and opiate analgesia, and it can be kept for 48 hours minimum. The problems with these is it causes high discomfort. Patient requires hospitalization. Oxygen therapy should be given via mask, and patient should be sedated because of risk of hypoxia and aspiration. And because of this, the patient has risk of hypoxia and aspiration. So this is the Belloc pack. We use gauze pack, which is rolled and threads are tied to this. We pass a Foley's catheter or a normal catheter through the nose and bring it out through the mouth, and we connect the gauze pack to this catheter and bring it into the choana. So this is pushed into the choana, and this is posterior nasal packing. Okay, the threads are then brought out through the nares, and it's tied anteriorly around the columella. And one more thread is left hanging in the nasopharynx so that the pack can be removed after 48 hours. This is another way of posterior nasal packing using a Foley's catheter. All right. What are the complications of most postnasal packing? Again, pain, hypoxia, sinusitis. This sits exactly at the level of eustachian tube orifice. So there's blockage of eustachian tube. Eustachian tube dysfunction happens, leading to medullary effusions, displacement with airway obstruction. Alar, columnar, or palatal necrosis can happen if it is fitting too tight. Then dysphagia will be present, and even toxic shock syndrome can develop. The other adjunctive measures are hot water irrigation. You irrigate with 50 degrees Celsius warm water. It stimulates the extrinsic pathway of coagulation that stops bleeding in many patients. And even systemic medical therapy can be given as adjuncts like tranexamic acid and epsilon aminocaproic acid. And these drugs are contraindicated if there is a pre-existing thromboembolic disease. And the other adjuncts are nasoseptin cream, petroleum jelly, and ice packs. Going on to surgical management, ligation of the blood vessel, if there is an intractable or uncontrolled bleeding in spite of anterior and posterior nasal packing, then the next option we have to think of is to ligate the blood vessel. The sphenopalatine artery is the most common artery of epistaxis, and this is the most commonly ligated artery these days, followed by internal maxillary artery and external carotid artery. And if there is specific bleed from the anterior posterior ethmoidal artery, then they can also be ligated. ESPAL, that is endoscopic sphenopalatine artery ligation. This is the closest source of bleed in the nose, and it can be done under general or local anesthesia. It has early intervention, hence there's a short hospital course, improved bleeding control, and no discomfort of packing. The success rate is maximum, that is 87 to 100% with ESPAL. You know, this is the closest vessel to the nose. So when this vessel is ligated, there is less chances of developing, communications from other branches, anastomosis from other branches fails to develop, and so the bleeding is well controlled. This is an endoscopic sphenopalatine artery ligation. You know, the middle meatal antrostomy, that is the maxillary antrum is widened, and then we elevate a flap to identify the sphenopalatine foramen. We have identified the sphenopalatine foramen, and then cauterize the sphenopalatine artery, which is coming out of the sphenopalatine foramen. So this is again a picture showing the sphenopalatine foramen with the sphenopalatine artery exiting out. This is a bony fragment called the crista ethmoidalis, which sits just anterior to the sphenopalatine foramen and acts as a landmark for identification of the sphenopalatine foramen. This is the ligatures put on the sphenopalatine artery. What are the complications of ESPAL? There can be a rebleeding which can happen. Infection, sinusitis can happen, nasal crusting, adhesions, palatal and nasal paresthesia because we are interrupting the sphenopalatine nerves. There can be decreased lacrimation. Septal perforation can happen due to reduced blood supply, and even inferior turbinate necrosis can happen because of less blood supply. IMAL, that is internal maxillary artery ligation. It was used prior to ESPAL, but its success rates is less compared to, excuse me. Slide is visible now?
Yes, sir.
Okay. So the success rates of this is less compared to endoscopic sphenopalatine artery ligation, because when you ligate the internal maxillary artery, there are more chances of developing cross circulation from the other vessels, and thereby the success rates are less. It should be done under general anesthesia through a transantral route. Nowadays, Even an endoscopic transnasal route can be taken to ligate the IMA. That is, I'll show you the picture. That will be easy to understand. See, this is a sublabial approach. You open the maxillary sinus through the sublabial approach. That is, you do a Caldwell look, and then once you open, you go to the posterior wall of the maxillary sinus. The posterior wall of maxillary sinus is removed. Once you remove that, you will enter into the pterygopalatine fossa. There in the pterygopalatine fossa, you will identify the terminal branch of maxillary artery, that is the internal maxillary artery and all its branches, and there you ligate all its branches as well as the IMA. Complications include infraorbital nerve damage. You see, when we enter into the maxillary sinus, at the roof of the maxillary sinus, you will have the infraorbital nerve coursing. So there can be damage to the infraorbital nerve. And these anterosuperiorly, you will have the nasolacrimal duct coming down, and that can be injured during this procedure. And oroantral fistula can be done, can happen due to the sublabial approach. There can be sinusitis, dental damage, and paresthesia, facial and gum paresthesia, ophthalmoplegia, blindness. Most of these complications can be prevented by endoscopic endonasal approach these days. The external carotid artery ligation is even more inferior to ESPAL and TESPAL. It should be done under general anesthesia most often. The complications include wound infection, hematoma, neurovascular damage, hypoglossal or vagal injury, and it has a low success rate. As I already told, the cross circulation easily develops. So there's an external approach for the external carotid artery ligation. You have to identify the bifurcation of the common carotid to the internal and the external carotid artery, and you have to ligate at the origin of the external carotid artery to prevent the bleeding. Is it visible? Hello?
Yes, sir.
Okay. Ethmoidal artery ligation, when there is a specific bleeding from the anterior or posterior ethmoidal artery, then it can be done by endoscopic technique as well as external technique. You you do a precaruncular incision, go through the orbital periosteum, and you elevate and identify the anterior ethmoidal foramen and ligate the anterior ethmoidal artery if it's bleeding, or if it's the posterior ethmoidal artery, then you can identify the posterior ethmoidal artery and ligate it. Embolization is a newer technique. If there is an uncontrolled torrential bleeding in spite of all the vessel ligation, then you do angiography. It's a CT guided angiography. You identify the blood vessel and you give in embolizing agents. There are various embolizing agents. This is how the angiography is done. You can see the bleeding spots in this area, and you give various agents like polyvinyl alcohol, gel foam, tungsten, metal coils. These can be used and injected into this area so that it stops further bleeding. The problem with this is that there has a whole lot of complications as far as embolization is concerned. They can be rebleed. So in embolization, there can be the embolic agents which you use, like gel foam, can go into the systemic circulation. It can go to the internal carotid system, can cause stroke. It can enter into the ophthalmic artery, causing blindness. It can cause carotid artery dissection, facial skin necrosis, paresthesia, and it is contraindicated when there is anastomosis, extensive anastomosis with the internal carotid artery, severe atheromatous disease, or there is allergy to the contrast material. When there is a sharp septal deviation or sharp spur, you can do a limited septoplasty or submucous resection. When you elevate the flap itself, there will be an interruption of blood supply and thereby controls bleeding. Septal surgery and all will be dealt with for you in subsequent classes. If there is a recurrent epistaxis, then you have to rule out aspirin use, liver disease. If there's septal perforation, nasal tumors, or use of topical nasal medications. If bleeding site is seen, again, cautery has to be done, and chlorhexidine neomycin cream can be used topically. These are the causes of secondary epistaxis: leukemia, myelosuppression, trauma, frontoethmoidal fracture, post-surgery, inferior turbinectomy, and already I told anterior ethmoidal artery bleeding if it's present in a mesentery, and warfarin use, and nasal tumors like JNA, hemangiopericystoma. And these are the various methods of controlling these secondary causes of epistaxis. Thank you. Thank you, guys. Thank you.
Thank you.
Any questions?
Thank you, sir.
Thank you. Thank you.